I'm Dr. Ed Martin for Ivy Family Health Updates. I'm joined by my sister, Dr. Catherine Martin, and my brother, Dr. John Martin, to talk about hospice. I'm the Chief Medical Officer for Home and Hospice Care of Rhode Island. A common misconception that people have about hospice is that it's a place, and it can be a place, but it's not necessarily a place. It really is an approach to care by a team. The team might include a nurse, who might be the person who goes out to the house and does the initial assessment, a social worker who might be going out and assisting the patient and family, a chaplain who might be assisting with spiritual care, a nurse's assistant who might be going out and doing bathing and dressing and assisting with those duties, a physician, a pharmacist, and basically all of these members of the team come together to assist the patient and family with this terminal illness. As I mentioned, it may be a place, it may be an inpatient unit, but hospice care can also be provided in a patient's home, the most common place that hospice care is provided in this country. It may be provided in the nursing home or in some places in the hospital as well. But the focus of hospice care is somewhat different than medical care per se, because really the focus is on caring. For most patients on hospice, cure is not possible. And so at this point in their illness, the focus really is on maximizing the quality of life for whatever time they have remaining. The focus also goes beyond simply physical comfort. As a physician, my focus tends to be on that. I'm worried about the pain, getting the nausea under control, making sure the patient's shortness of breath is controlled. But really, I think hospice care goes far beyond that. And when a patient's on hospice, the focus of the team really is looking at not just their physical comfort, but their emotional comfort, their spiritual comfort, and their psychological comfort to maximize the quality of life for whatever time they have remaining.
And, you know, Ed, I always had thought that hospice was just for cancer patients, but really anyone who has a limited lifespan can go to hospice or get hospice care, correct?
Exactly. Initially, hospice was only cancer patients, but now it can be any illness that's causing the patient to have a limited life expectancy. It might be heart failure, it might be chronic lung disease, it might be a neurologic disease like Lou Gehrig's disease, ALS, or Parkinson's, or dementia. Really any of these illnesses, or for some patients it's multiple illnesses. They may have several illnesses, heart disease, lung disease, liver disease, that combined really are going to cause them to die in the coming weeks or months, and so they would be eligible for hospice care. I think one misunderstanding is the 6-month requirement, because that is a requirement, but there's no requirement that the physician promise that the patient die in 6 months. Obviously, that's not possible, but that's a common misunderstanding, and physicians are sometimes reluctant to certify that their patient is eligible for hospice. And really what Medicare is asking, that in our clinical judgment, that it's likely that the patient will die in 6 months. So some patients are on hospice for longer than 6 months. They may be with hospice for 9 months or a year, as long as they continue to be eligible in that regard.
Okay.
And many patients and their families, and I think this is another misunderstanding, they're afraid to go to hospice because they're under the impression that you have to stop all treatment. And if you stop all treatment, they're going to die much faster. Is there any truth to that?
Well, I think in the past that was often a more common misunderstanding about hospice, and I think it may have been true at times, that the notion of hospice was when you start on hospice, you stop all treatment, you put on your pajamas, you get into bed, clear off your medicines from the bedside table, get the bottle of morphine, and get on with the dying process. And I think that couldn't be further from the truth nowadays, because nowadays many patients will continue their treatments. Many of their treatments are very appropriate in terms of managing their symptoms. A patient with cancer may still be getting some radiation to help control their symptoms, may even be getting some chemotherapy. A patient with heart disease may be continuing on their heart failure medications. So I think really that the days of stopping treatment are over. And actually there was a study done several years ago to really look at how much more quickly hospice patients died, because I think that was the conventional wisdom, that hospice patients would die more quickly. So a study was done looking at a number of diagnoses, including heart failure and a number of different cancers, and in every case, the hospice patients actually lived longer than the patients who didn't go to hospice, in some cases significantly longer. Now that study raises many questions as it answered. We don't know why the hospice patients lived longer. Was it simply that they stayed out of the hospital in those final months or weeks of life? And we all know the hospital is a great place to be when you have a reversible condition or something that needs that kind of attention. But for many times a terminally ill patient, only bad things can happen in the hospital. They develop resistant organisms with many of the things we're reading about in the paper, like the methicillin-resistant staph, MRSA. They run into problems with procedures. They develop complications. So it's unclear if that's why they live longer, or if it's the good palliative care at home, the team coming in and really assessing the patient. And I think along with that goes the misunderstanding that somehow morphine will cause our patients to die more quickly. And I think that certainly was the conventional wisdom for years, that once the patient starts morphine, they will die quickly. Again, there's very good evidence now that that's not the case, that patients actually don't survive any shorter or longer once they start their morphine, but they can certainly live better and have greater quality if their shortness of breath and pain and other symptoms are well controlled with some of these important medications.
And to be eligible for hospice, do you have to be referred by your doctor, or can the family refer you? How does that work?
No, that's a good question. The doctor will always be involved in the process, but the doctor doesn't have to start the process. So many times, actually, it's the patient's family that calls. They've been to the doctor's office, and the doctor said, gee, there's not much more we can do here. The family comes home. They understand, well, gee, our neighbor was on hospice, and so they'll call hospice. Hospice typically will then call the physician to make sure the patient's eligible. The hospice nurse will go out to the house, do an assessment, again, to confirm that the patient's eligible, and then the patient can get started with hospice care.
Very good.
Very interesting. Thank you, Ed.
Thank you.
Thank you.